The purpose of this case is to show you one of the many different appearances that adenocarcinoma of the lung can have, and to remind you not to forget about adenocarcinoma, especially when you have such as a severe abnormality. Now, this was this man's presentation. He's in his 50s, and you can see that almost the entirety of his lung parenchyma is affected, the right lung much more than the left. And most of you provided a very good differential diagnosis. You see that there are some perilymphatic nodules in the areas that are less affected. And often when you have something this severe, it's important to look at the less affected areas to try and get clues as to the patterns. We see many nodules that are studying the fissures, studying the pleura. Then we have to deal with all this consolidation on the right. His right lower lobe's completely consolidated. There is focus of cavitation here. Same thing in the right upper lobe. There's a little bit of volume loss too, and a small effusion on the right side. Now, he doesn't have a lot of lymphadenopathy, but that shouldn't dissuade you from this being cancer. Another big clue in cases like this, if patients have lungs that look this bad and they're not intubated, this guy had a productive cough, but otherwise wasn't that sick. That's another clue that you're probably not dealing with at least a severe infection, that this very well may be adenocarcinoma as it was in this case. So I just briefly wanted to show other patterns. Here's another patient with adenocarcinoma. They have a little bit of cavitation in the right lower lobe, but you can see multiple other different patterns. This even looks like an atoll or a reverse halo here. You see that there are ground glass and central lobular nodules, more ground glass here, maybe a little bit of crazy paving here. Same story though, this person wasn't that sick when they came in. Here's one that looks much more like crazy paving. You see some thickening of the inter and intralobular septae with predominantly ground glass opacity. This was mucinous adenocarcinoma. Here's one that looked more like just more nodular consolidation. Could have been confused with pneumonia. This patient was asymptomatic and this had been present for at least a year. Now, here's one that's a pattern we occasionally see, and these are 3 sequential studies performed at 5 to 6 month intervals. We see what looks more like a bronchopneumonia, and you see these are central lobular and tree and bud nodules. But over time, they persist in a similar distribution and continue to get worse. And he wasn't diagnosed until this final study here. But you can see this is the so-called aerogenous or airway spread of adenocarcinoma. Here are 2 more. And this illustrates one of my favorite patterns, which is the Cheerio. And you can see, just like the breakfast cereal, we see these small little cavitary and pseudocavitary nodules, more discrete consolidation on this side. This is another pattern you may see with adenocarcinoma. The Cheerio has its own differential we're not going to get into at this point, but you can ask me about it. And then this is the other one, the bubbly BAC. And this is how this patient presented. If you see a big, complex cystic lesion like this with soft tissue in the walls, this is adenocarcinoma until proven otherwise. This was actually on a spine CT from before and wasn't really commented on in this case, but this is how these will tend to evolve. Here's another one, same thing, bubbly adenocarcinoma. Notice the soft tissue in the wall as it just obstructs, destroys the lung, whatever the process is here for giving you this area of cavitation. But this soft tissue in the wall is the key. And finally, it can be scary like this. This was called atelectasis or scar. We see that there's a little bit more volume to this. And then 6 years later, it was actually not only on the right side, but also on the left. And you can see back on this first study that both of these areas of adenocarcinoma, this was bilateral adenocarcinoma. Here's one as well, miliary pattern or just diffuse random nodules. Again, adenocarcinoma, this is an outpatient. This is how she presented. And then finally, similar to the case we had, looks like a combination of just diffuse consolidation and crazy paving. So this is, again, mucinous adenocarcinoma, or so-called pneumonic type of consolidation. Finally, and I had this discussion the other day in the reading room, we don't talk about lymphoma that much, but lymphoma should always be in your differential as well, especially when it's chronic consolidation that you suspect is adenocarcinoma. They can look the same. You don't have to suggest it prospectively in all cases, but just remember, if biopsy comes back as a bulk lymphoma, that shouldn't be much of a surprise to you.